Alrighty, thank you very much, everyone. We are running on schedule. So I won't do long, lengthy bios. They're all on the website for everyone to look at. But we'll kick straight into it, and I'll introduce past District Governor Di Mawson, the Rorke's campaign manager. Please take it away.
Can I share the screen?
Please and thank you.
Share, let's have a look. Can you all see that?
Sure can.
Okay. And you can all hear me pretty clearly, I hope.
We can indeed.
I think being the first up speaker, thank you, Sean. Being the first up speaker is always a bit like warming the crowd up for the next best acts coming along. So I'll try my best to do that and keep it fairly short. I think, first of all, that thanks for the opportunity, basically, to provide an update to Finish the Fight platform. Now, the use of the word platform is being used here so that future campaigns in other parts of the world with the Global Fund will have the availability to exercise a similar program under Finish the Fight branding. And the partnership with the Global Fund Rorke's RAM has taken over 2 years from inception to where we are at present. And what I'd like to basically reflect on the pathway so far and highlight some of the activities planned for the future. One of the drivers for the platform is to draw attention to the statement that we have impact with potential donors and to stop a child dying of malaria every 2 minutes. And we all know this is an unnecessary loss of life and opportunity. And I think by the end of this talk, probably at least 8 children will have died of malaria throughout the world, that is, of course. And children under 5 represent some 67% of all malaria deaths, according to the World Health Organization. I think malaria can be eliminated through probably 3-pronged approach, really. First of all, is vector control, which we all know about longer life insecticide nets, etc. Improved case management and behavioral change education. However, for all these to be effective, it requires adequate resources, both financial and human. And that's what Finish the Fight's all about, is in fact raising funds for the work in Papua New Guinea, Timor-Leste, Solomon Islands and Vanuatu. The vision for Finish the Fight is, as you can see, to bring people of action together to get the Western Pacific Rim. And we define the Western Pacific Rim in this case because even though it's including Timor-Leste, to get certified malaria free. And the vision is also to stimulate other people of action, such as like-minded corporates and ultra-high net worth individuals to actually become donors. Now, the partnership with the Global Fund, of course, why isn't that working? Hang on. Okay. This is a little bit of the role of the Global Fund in these activities. And I think you can probably all read that, but basically, apart from the fee that's taken out by Rotary Australia World Community Service for administration purposes and running the campaign, the Global Fund accept all the money, and they use 100% of that without any overheads, effectively to support malaria prevention programs run by local experts in the Western Pacific region. Okay. And of course, the result at the end of the day is to save lives and increase overall economic productivity and break that cycle of poverty. What I want to do now is effectively to have a look at some of the past timelines to see where we're currently at. Around about June 2019, probably maybe a little bit before that, the Global Fund approached Rorke's RAM to be in a partnership to raise funds for work in Papua New Guinea, which was $9.12 million for the region in the highlands above 1,200 meters, because there'd been a shortfall in funding in that. Having agreed to join that partnership, we had to set up a letter of intent so that basically we could make the pledge at Lyon. And Lyon, when I say Lyon, that was the replenishment conference, which the Global Fund hold every 3 years, and where governments and private enterprise, private sector organizations pledge money for the next 3 years of operation for the Global Fund. at that particular replenishment conference, they raised something like $14 billion US. Now that was in 2019. In fact, in 2022 will be with the next replenishment conference will be hosted in the US. I'm not sure where, I'm not sure when, but it's only just been announced on Thursday that will be the case. Then in April 2020, we signed a memorandum of understanding. And in August 2020, we appointed a marketing consultant, which we worked then on the branding of the campaign and getting up the website and doing all the assets for the campaign itself. And the campaign was effectively launched in July 2021 with the uploading of the website. Planning timelines, I think just to highlight some of the areas which we're actually looking at to be attending at and sort of promoting the campaign as well. We've got two major events coming up with Rotary International, of course, which are the two conventions, which is the first one's in Houston in June 2022 and then May 2023. We've been participating in a special event at Houston in conjunction with the RAM Global, and that's RAM Global is the Rotary Action Group, and MPI, which is Malaria Partners International. And they're inviting basically the board of Rotary International and the board of the trustees of the Rotary Foundation, together with potential donors and high net worth individuals, to a cocktail function on the Saturday afternoon. That'll be quite an interesting one. We're also applying for a House of Friendship where we can effectively sort of display the finished part program. And I've also asked for a breakout session to discuss how Rotary or Rotarians can work with partnerships into international partnerships on a joint basis. And then again in May 2023, we've got the RI convention in Melbourne, and we're involved with organizing a 2-day Congress on malaria. And I want to talk about that a little bit later on. And again, looking at House of Friendship and a breakout session. Now, all this takes time and effort, and we have a team together. And you can see from the lovely faces on the screen there, that Tony Spring from District 9820 is the Deputy Campaign Manager. John Stockbridge is the comms person. Amanda Miller is looking after research, and Rotarian Adriana Lanting, she's in Los Angeles. She's also the chair of the board of Malaria Partners International, and she's helping us out in the US area. And Michael Haywood, who is past president of the Geneva Club. He doesn't actually live in Switzerland. It's more expensive to live there, so he lives just over the border in France. But he was very helpful when I went to the Lyon Pledge, because was in fact a past member or past employee of the Global Fund. So that's the team, and we're building on that as we go along and as we need to. Okay, now one of the main things I think about any campaign is the advocacy and it's very critical to success of any campaign to have that advocacy with other partners. APALMA is the Asia Pacific Leaders Malaria Alliance. They have directly financed the appointment of the marketing consultant, and together with the Global Fund, they provide an enormous amount of funds to help us get to where we are with that. Because obviously, as we're building up the campaign, we need to get funds in to run the administration, etc. And again, when we get the funds in, that'll obviously help to run the actual campaign again. Now, we're also in negotiation with the Bill and Melinda Gates Foundation and Rollback Malaria. We also, as I said before, we got connections with RAM Global, which is the Rotary Action Group, Malaria Partners International, Global Health Alliance we've been in contact with, and of course RAM PNG, and they all assist in promoting the campaign and gaining an understanding of the needs and activities worldwide and locally. So what are we asking actually? Okay. The campaign is not seeking funds from Rotary clubs in Australia as part of our memorandum of understanding, because those funds from Rotary clubs are needed to run the programs around Australia. And so what we are asking for is to invoke our Rotary network to allow us to gain access to potential donors in the corporates and the ultra high net worth individuals. One of the things we're looking at the moment is to establish a tax deductibility, not through RORCs, but in America, which we have to do a different arrangement so that any American donations, and we're working on that fairly hard at the moment, hopefully we'll succeed in achieving this, so that any donations coming from US citizens, they can actually gain tax deductibility under their tax system in America. And that's a pretty important part because we want to launch a campaign there just before Thanksgiving Day at the end of this month. And is when the time Americans seem to give a lot of funds to charity, etc. So what can the corporate expect? Well, these are just brief headlines, a curated program. And that's really working with them to wrap core initiatives with sort of bespoke tailored programs aligned to that's the corporation values and goals, and provide a measurable impact with clear demonstration of the impact their involvement has through the supply of global fund validated and ongoing data. So there's going to be interaction between those large or corporate donors so that they get a knowledge of what's going on in the program and where their money is actually going to. And obviously we're trying to create a committed partnership with them and a nurtured relationship where effectively a dedicated senior contact from Rotarians Against Malaria to ensure they have relevant access that they need to establish. Okay. I've gone one too far. Hang on, that's better. Where can you find us? Well, there's the website, https://finishthefight.org. And also you can see us on LinkedIn. And if you go to LinkedIn/company/finishthefight, there are a few little highlights and headlights up there, which you'll have to give you an idea of our campaign. And those assets are up there now and running. And the website, we're going through a second process of developing that to allow US citizens to get their tax deductibility. Okay, I just want to go back now to save the date for everyone. 25th, 26th of May, 2020. It may sound like a long time away, but it's not, in fact, in terms of trying to get things organized and trying to get a 2-day Congress on malaria going. We're modeling it a little bit on the first Malaria World Congress, which was held in Melbourne in 2018. And we've already got an organizing committee going. We've actually appointed a professional conference organizer. And we've also got a speaker committee going, which is headed up by Bruce Anderson. And I just want to point out that RORCs have agreed to underwrite the Congress. We're dealing with MPI in America and other places to support and help with this particular Congress. And we've got a lot of work ahead of us, but by the Houston convention, we will have an early bird registration fee out. And please look for that between those dates when the Houston convention's running in June. That's, I think it's 4th to the 8th. Just make sure you log onto there to get your early bird registration. We're looking to probably get over 500 people at the Congress. It's going fairly well. There's a lot of work involved in that, and we'll update you again a little bit further on. I think that's all I need to say. That'll probably keep you ahead of schedule on this, and I'm happy to answer any questions.
Outstanding. Thank you very much. Our first question, I believe we have, is from Andrea Grosvenor. She asks, is there modeling to know how much it would cost to fully eliminate malaria in our partner countries, and how far will 12 million US go towards this aim?
Okay, yeah, Andrea, thanks for that. I can't answer that directly. I mean, it's how long's a piece of string in some of these issues, I think. Obviously, COVID-19, we don't know yet the full effect on what that's had on these countries in particular. And I think I guess the $12 million really is to get the campaign to finish the fight going, so that basically in the long run, Rotarians will get more involved in actually fighting malaria throughout the world. And that's one of the objectives I think that the Global Fund have, is that malaria becomes the next big thing for Rotary to take on, other than what they've done in the last successful time in polio. No, Andrea, I'll have to get back to you on that one. Can't answer it, sorry.
Fantastic, thank you. Graham Jones asks, is there a place for vaccine involvement in this program?
Thank you, Graham, for the question. No, look, at this point in time, not at this point in time. There's no what's saying for a vaccine. It's all basically intervention work. However, I'm just waiting to get an answer back from the Global Fund on this. The new strategy that they just put out on Thursday, there's maybe a slight loosening, I suppose, of their effect in terms of vaccines. But I'll have to confirm that with the Global Fund, find out where they're going. I'll put the question to them, and I'm waiting for an answer back.
Fantastic. Do we have any questions before we finish up? Jenny's just asked, can you please mention that there are many great scientists on the Melbourne conference?
Yes. Yeah, look, we're working with also in the community. We're working to work with, get, first of all, effectively world representation there. And then we're looking to get a sort of scientific side of things, and also the work that the Rotarians do throughout the world. We want to highlight that basically for so the people coming from overseas to the convention will actually join in the Congress there. Yeah, we've Maxine's on the committee, Jenny's on the committee, and Bruce can tell you more about that too, because he's the speaker chair. But yeah, no, look, it's going really well, and we're getting a lot of scientific background and help from people in the industry, which is great.
And she's just given you a follow-up as well. What's the role of Rorks and RAM in the conference?
The role of Rorks and RAM, basically, were Rorks and RAM. I mean, Rorks are actually underwriting the Congress, and effectively, we will be the lead group in there to make sure everything happens.
All righty. Fantastic. Thank you very much, Dave Mason. That was a fantastic presentation. I thoroughly enjoyed it. Michael Moore is our next speaker. He's our past district governor. I'm sure he'll appreciate the extra minute or two. He does like a chat. So Michael, without further ado, would you like to take it away?
Thanks, Sean, very much. I just in the process of sharing my screen and getting ready, and to thank Di for warming people up as he said he would. Now, Sean, have you got my screen in front of you?
Yes, looks fantastic.
Thank you very much. And my experience in my role is a bit different from what we heard yesterday and what we've heard this morning, which is really focused on malaria. Whereas my role today has been to really focus on actually how we can influence government policy in order to achieve the goals that everybody's aiming for. And I'd like to begin by acknowledging that I'm on the land of the Ngunnawal people, pay my respects to the traditional owners of the land around Canberra, and to all other Aboriginal and Torres Strait Islanders who may be present today. And let me start really by talking about public health. So over the last year, many of us are really beginning to understand much more about what public health is. And here's the fundamentals. It's about protection, prevention, and health promotion. But there's a distinction that we make, and it's interesting talking about malaria, because when Margaret Chan of the World Health Organization asked myself and others, members of the World Federation of Public Health Associations, to develop this global charter, they wanted to move from a disease-specific focus to what is a broad health focus. So it was AIDS really that brought us to a disease-specific focus. And how do they all work together? And there had been attempts previously, the Declaration of Alma Ata, the Ottawa Charter, the Millennium Development Goals were all about trying to get a broad approach. So this was developed in conjunction with the United Nations Sustainable Development Goals. And the 7 areas of action and the fundamentals, when somebody said to me, well, what is public health? Well, it's about protection, prevention, and health promotion. And that distinguishes it from people's mind, which immediately goes to public hospitals. So we're talking about a completely different concept, as has become very, very clear since the advent of the pandemic. But you can't do these without the enablers. And it means good governance, accurate information, effective advocacy, and capacity building. In fact, you can see in the diagram, we didn't have the descriptors. It was actually after Donald Trump that we started adding the word accurate information, and then broadened that out. So one of the things that has been interesting to me has been Rotary's areas of focus and how they align with the Sustainable Development Goals. So when we look at now the 7 areas of focus, and you go to what's in the Sustainable Development Goals, and if we look to the top left, they're probably hard for you to read, but there's life below the water and life above the land. For us, that's environment. There's a run of health, good health and well-being, but there's maternal health, there's infant health, there's women's health. So when we look at them, they actually align very, very nicely. And I think when it comes to seeking to influence, particularly governments, we say we are consistent with the United Nations Agenda 2030 for a Sustainable Development Goal. But should I be the person who's trying to have influence becomes a question, I think, that each of us asks when we're actually trying to do the job. So for some of us, getting out there, providing bed nets, sending them to specific areas, or helping with vaccination, these are all very, very important things, but they can't happen unless we have a supportive government. So people say to me, yeah, but Rotary is non-political. And I think that we really need to develop our understanding of what we mean by non-political, because everything about public health, about making a difference is political, but it's non-party political. And I think it's really, really important for Rotarians to understand that distinction that we have, because and it can be illustrated by looking at our achievements with polio. How do we get there? Well, it was about influencing governments. It's about influencing politicians. It's about influencing bureaucrats. And even the negotiations that were made with the Taliban over the last few years have been absolutely fundamental to being able to continue the polio program in Afghanistan. And what an achievement. Only 2 cases of wild polio virus so far this year, at the beginning of the year, 9 months ago, compared to about 130, I think it was, last year. And most of us know if we go back 300,000 cases, over 300,000 cases a year when the Rotary took on getting rid of this disease. But it has been about influencing governments. It has been about influencing politicians and bureaucrats. So when we want to make a difference in malaria, all the things that we've seen are absolutely fundamental, but we have to have the support of governments and bureaucracies. And certainly when I hear Andrea giving her talk on Rotary, and she did to our club only a few weeks ago, and she looks, in one of her slides, talks about the way she's working in Timor-Leste with bureaucrats, with government. And I think it's really fundamental to think about how we frame it. And I hope, Di, that when you have the 2023 Congress in Melbourne in late May, and I'm hoping to be there, that there will be a focus as well on this type of influence and how we get there, and in this year how we do it in order to change lives. So how do we go about it? And that's the fundamental step for me. I'm just going to take a sip of water. Thank you very much. So this is builds on Kotter's change management theory and is what my PhD was based on. So governments are not interested in doing specific things unless there is a sense of urgency. And talking about every 2 minutes a child dies of malaria, I can't think of a more effective way of establishing a sense of urgency. You also mentioned working with other people, and Maxine Whitaker yesterday put a huge effort into what are the other CSOs, the community service organisations that are working on malaria. You don't try and do these things by yourself. You work with them in order to influence government, as well as to get better outcomes in other ways. I think the most important of all these things is developing and maintaining influential relationships. So it's an important thing for a Rotary to understand who are the key players and how to do it. And having Camilla speak yesterday from Foreign Affairs, I think was a really important illustration of how you do this, because that's a really important relationship at the level of the bureaucracy. But we also need to make sure that we're speaking to the health minister, to the ministers with responsibility for the local area. And I know Ian Risley has been working with Greg Hunt, who happens to be his local member, as another example. You've got to know where you're going. What is the specific ask that you want? And I have to say, if I go back to days many years ago, 2 decades ago, when I was a health minister, and people would come in to meet me, but they had no idea what they actually wanted. They knew what was wrong. They didn't know what they wanted to see as the change. When you are really specific about what you want to see changed, then we actually can be more effective in getting what it is that we want. And when you know that, then you can communicate that vision for buy-in. And over the last day and this morning, I've heard very, very clear communications of what it is that we want, and whether it's on vaccination, on vector control, and so on, the areas that Di mentioned. That was a very, very clear communication of where we want, including, of course, building relationships with funders. The next element is to bring others in around you, to empower broad-based action. When you're trying to influence government, think about, is it worth getting Rotarians to write to their local members to ask, can they support this particular ask, this clear vision that we have? And that also includes communicating to the media, because don't forget that politicians are influenced by what they read in the media, because they do need to get elected the next time round. The one that's, these steps are really sequential steps, with one exception, and this is the exception, being opportunistic. So when I'm teaching about public health advocacy at universities, as I do occasionally, I point out that that what we need is a really clear way to influence people in a short time, and we call it the elevator pitch. You've probably all heard of the elevator pitch, and we actually practice doing an elevator pitch, because you just don't know when you're going to be standing next to Greg Hunt at the soccer while he's watching his kids play, if his kids happen to play soccer. And what's the idea? What's your clear vision? Can you communicate it in a matter of a short while? The next element I think that is fundamental is generating short-term wins and feeding back to your funders, to those you're trying to influence, so you get continuity. Short-term wins are really important in political terms, because although many politicians like to think they have a long-term vision, although it's very easy to say they only think to the next election, there's an exaggeration there. What's happening is that they have to get re-elected in order to carry out a long-term vision. By the way, there's not that many that have a long-term vision, but enough do, and particularly when we have already provided the vision for them. So short-term wins are important so they can sell it to their own electorate. Persistence is another important thing, and Professor Rob Moody says about advocacy, there's 3 fundamentals in advocacy, and they're the 3 Ps: persistence, persistence, and persistence. And finally, how do you incorporate those changes into culture? So like polio, once we have won this, how do we build into it so that we make sure that we don't get outbreaks, and we continue to build on those things? Those are the general elements that I have developed over the years. in consultation with others in order to influence government. And it's something that I think Rotary could improve its efforts on if we were so minded, because we do so much work around the world. We do good in the world, and I think we can do better. So really, I want to make sure that I stay well within my 20 minutes. And so I'm hoping that some of those ideas did hit home. And I'm very happy to answer any questions, Sean, should anybody have them, or save you some time.
Thank you very much, Dr. Michael Moore. That was very efficient. I'm thoroughly impressed. Does anyone have any questions for Michael? Do you want to pop them in the chat?
See, people weren't quite expecting this one, Sean. They were more expecting just to listen to more things about malaria. Yeah.
G'day, Michael. It's John McLaren here.
John.
I just wanted to pass a comment on what you've been saying. I think that your comments on Rorke's and Rotary's advocacy is absolutely vital. And I do believe that we're now at a crossroads in terms of Rotary's regionalisation exercise. And I'd certainly like to talk with you further about how we can develop this. I think what you've nailed it in quite a number of areas. Thank you very much.
Thanks, John. And look, it really is a bit of a change for Rotary, but one of our challenges has been not having a speaker for Australia, although Jessie Harmon, I think, has done very effective work across Australia, but she's got bigger responsibilities across Australia, New Zealand, and the Philippines.
Michael, Gary Davis here. I just thought that was a great presentation, and the key point is that you have to know what you want to get out of someone. It's no good going in there and talking as an old public servant and being there with ministers when people come in. If people don't know what they're talking about or don't know what they want, it's not much of a productive conversation at all. So I think that was a really key point of what you said.
Thanks, Gary. One of the things I emphasise when I'm teaching is, of course, that you need the evidence when you go in to speak to a minister, but also you need the anecdote. It's a combination of evidence and anecdote that really carries the day. And boy, the anecdotes around malaria and children, as we've heard again and again, are really strong and easy to use.
Yeah, winning the mind and the heart, that's important.
Yeah, and I emphasise, looking at the question coming in from Jenny, for example, that we have non-party political. Yes, we're political. I used it with a small p, but really important to be non-party political. And I see Maxine has her hand up, Sean.
Yes, Maxine, would you like to go ahead? You're just on mute at the moment, sorry.
As we all do. Thanks, Michael, that was great. I think one of the questions for us, particularly in our region and the countries that Jenny's talking about, is we're actually at the elimination end. And there are a lot of partners in the world about malaria advocacy, but what I find is their messages are still very much about control, whereas what we're asking, as Andrea was asking earlier, was for that elimination eradication, the costs are actually going to be higher. That was what was discussed at the Global Fund Board this year. And I think Rotary's should reflect upon the experience they've had for that long tail for polio elimination eradication. They probably are one of the experts in trying to advocate for that tail end, because it takes a long time. It costs more than people would expect for a disappearing disease. And it actually needs to be very careful about its, for Africa, it's saving children's lives. In our region, it's not saving children's lives. It's actually young men going to work or preventing it coming back and killing people. It's sometimes a harder message to get across. So maybe some comments from you for our region.
I think you've actually almost answered your own question, Maxine, but our lessons from polio and the cost of maintaining surveillance in particular has been really quite extraordinary. but we don't know about the disease and how it's going unless we're testing the sewers, doing all of those other things. So the cost of the tail end is always much, much more than we expect it's going to be. And as you say, Rotary is very experienced in this, and so I think that it's important that that experience is brought to bear working with our partners.
Fantastic. Jenny, would you like to have a comment? I think she might be having some microphone problems.
We can have a quick look in chat, Jenny, if you've got something else.
Hear me now?
Oh, yes,
Yeah.
that's better.
Right,
Perfect.
thank you. Just to thank Michael, that was terrific. What I have always been a bit concerned about was that Rotarians work from their heart rather than being framed by, public health theoretical framework. And I think that your presentation highlights the need to be more aware of what we're doing and doing it more, informed. I think the other thing, and what you've pointed out too, is the need to also be aware that we are confined by Paris 8 Declaration of Aid Effectiveness. We don't go into countries willingly and very generously, but we also need to be informed, guided by them and driven by their needs. So I think I'll stop there. So, the stuff we've been looking at, partnerships, health system strengthening, integration of community services, I think that's the way to go, not just vector control. So, so REM is not just vector control. Thank you.
Fantastic. Thank you, Jenny. Just quickly, if I could get one in as well, Michael. What's the line for Rotary with political and non-political? Like, how can we cross it, and how can we avoid crossing that line?
Look, I think it's just non-party political. I think it's reasonably straightforward. We work across the political spectrum. We don't make judgments. Of course, we all have our own personal view. And for those who don't know, I was an independent member. So in some ways that sort of fits in with the way I would think. But working with my colleagues right across Australia, I still think that everybody in politics knows that those who seek to influence go across the party lines. It's not something that upsets anybody, provided you actually set out from the beginning to be non-party political. I think that's really, Sean, how we make sure we keep that really important non-political thinking of Rotary.
Fantastic. Thank you very much. Well, that brings us almost up to 10:41, so we are well on schedule. Fantastic. Thank you very much, Michael. Always good to hear you talk. We'll move on to our next speakers now. So we'll have Dr. Dan Evans and Jeff Smith speaking to us. Dr. Dan Evans is the founder of Cross-Sector Development Partnerships Initiative, and Jeffery Smith is the co-chair of that initiative and a former CEO of the Asia Pacific Leaders Malaria Alliance. I'd like to hand it both over to you. Take it away.
Thanks very much. First, the XSPI would acknowledges the Wurundjeri people on whose lands we work and pays respect to the elders past, present, and emerging. So this talk's going to be in two parts. I'm going to open up with a high-level overview of XSPI, and then Jeff Smith is going to talk quite specifically about the RAM Australia-led project in Timor-Leste and NTT province. So forgive us because my part will be reasonably rapid, but Jeff and I are quite happy for the presentation to be available to anyone who's interested. So firstly, looking at XSPI, we see that there's an opportunity to chase the holy grail, which is effective partnering. We believe Australia can position itself uniquely, particularly by trying to break down the barriers and adopt a more integrated Team Australia type approach to international development. And quite specifically, we're trying to break the silos down between government, business, NGOs, philanthropy, stroke private capital, and academia, health, medical research. We're talking about 5 Australian stakeholder sectors, obviously always partnering in country. essentially, we believe the real value comes, if you like, from tapping into the business sector, getting them mobilized. We cover 19 Asia-Pacific countries, but critically, we prioritize one each in Melanesia, that's PNG, and then Indonesia for Southeast Asia, and then Bangladesh for South Asia. So that's where we're prioritizing the initial work for XSPI. This is busy. I'll just point out the critical aspects of this slide. Essentially, we have a hypothesis that this approach hasn't been taken elsewhere overseas. We've now tested that hypothesis with a piece of empirical research covering 23 entities, including 9 OECD countries, 8 international foundations, including MMV, okay, and then 6 multinationals. We can confirm now, to the extent that that's representative, which we're quite confident is, that there is a market gap in cross-sector partnerships across these 5 stakeholder sectors. So we believe we've got a unique value proposition, which is essentially about incubating, seeding, or accelerating cross-sector partnerships within Asia-Pacific. We've got a 5C approach, okay? Critically, we're catalysts, co-developers, coalition builders, conveners, and collaborators. Most essentially, what we are not is project funders or project managers. Now, that doesn't mean we don't work hard to assist finding funding or helping transition into project management. I'll talk more about our framework shortly, but that's really important to understand what we're not. And I'll speak about our unique structure shortly. So what are our objectives for this first 18-month horizon? One, the critical objective was for each of those 3 priority countries, we initiate 2 proof of concept partnership pilot projects and create at least 2 strategic partnership platforms, which would be the basis for an annuity of potential ongoing projects. This is busy, and I'll speak to it fairly quickly, but this is actually quite essential. Business for Development is our host entity, and what they do for us is they provide all of our business support systems on a pro bono basis, and they auspice for us so that we can get DGR status. So Business for Development, quite essential for us. We've put together what I consider to be a very high quality advisory council, critically trying to get ideally 3 or 4 high-level executives from each of our 5 stakeholder sectors. Importantly, these people represent not only their employer, but the sector that entity is part of. So Burnett's a good example. Burnett really represents all of the medical research institutes here in Australia. So we're really quite excited about some of the people we've added recently, including Claire Moore, former Queensland Senator, 18 years in the Senate, and then Professor Farhad Reza from Monash. He's got all the international responsibilities from Monash. And so we're really very pleased about the quality of our advisory council. They don't have governance role. They have strategic oversight role. Our governor sits in that steering committee, which is composite of some of the advisory counselors, and then the country leads for each of our 3 priority countries are part of our steerco. An essential element of what we put together, which was not something we originally envisioned, is our expert network. This slide slightly dated. There's now 40 people on the expert network. Rotary is well presented. So Dr. Jenna Kerrison is on the expert network, as is Russ Stevenson. And then most recently, MMV board member, the only one from Indonesia, Yuli Ismatono, has joined as part of Indonesia working group and part of the business sector. So the country working groups, that's essentially our operational model. Okay, that's how things get done. And they're composite between Australians, nationals, and Australian expats operating in country long term. It looks complex, but in fact, it's proven to be quite effective in doing the things we're trying to do. Just really briefly now, this is how we go about initiating pilot projects. We did stakeholder mapping covering 19 Asia-Pacific countries, mapping out across our 5 sectors where they were active essentially since 2017. So we've got that. Obviously, it's all public domain information, so it's not as complete as it could be, and we work to refine that. We've created these 3 country working groups, and it's their role to try to initiate these partnership pilot projects and find strategic platforms. Okay, so they go through and work to qualify projects and then to build out a project consortium. When Jeff speaks, he'll reference that a bit more. Really quickly, we've got an empirical research agenda around issues that we've identified that were not already being addressed by anyone in Australia, okay? Most critically, the global cross-sector leaders, I've referenced that at the beginning. We're working with the University of Queensland to try to create a knowledge platform around international development. And this is all pro bono. And we're working with Accenture on a pro bono basis to look at this issue of sustainable NGO business models and the role of cross-sector partnering. So since July 2020, we've actually created quite a broad, if you like, ecosystem of partners, some of whom are just network sort of participants, but it's actually quite substantial across the 3 country working groups, across our research agenda. And then you can see the caliber of entities presented on our advisory council. Importantly, DFAT created the opportunity for us to present a talk to the New Colombo Plan's Momentum series, which we did this past April on essentially a Team Australia approach. This is our 5-year strategic vision. As I said, we're just completing Horizon 1. We envision 2 further calendar years for Horizon 2, where we'll deepen what we're doing in the 3 priority countries and ideally add 1 country more to each of those 3 regions: Melanesia, Southeast Asia, South Asia. Very high probability we'll feel that Timor-Leste is the appropriate country to add as part of what's considered Melanesia. But the other critical aspect of Horizon 2 is we're going to work very hard to localize, if you like, to be locally led, which is a really important sort of direction that the NGO world is going. And we're very mindful of that. And we're increasingly trying to recruit nationals onto our working group so that we can get to that stage. So again, I apologize for the fact that it was a very rapid introduction. Material will be available, but I'm keen to pass over to Jeff Smith now to talk about the work that RAM Australia is the lead partner in. Across to you, Jeff.
Thanks, Dan. Trying to share my screen here. So, yeah, thanks, Dan, and let me kind of give an example of what we're trying to accomplish through what Dan has set up. I mean, it's quite amazing to establish these multi-sectoral partnerships to address this challenge. So it was about 6 months ago, a task force was established to take on Timor-Leste and in NTT province in Indonesia to accelerate elimination. Now, the heads of government have all committed to the 2030 goal for eliminating, but some countries have the opportunity to accelerate, and we think it's worthwhile to move forward the target dates for both NTT and Timor-Leste to 2026. Now, Timor-Leste is very near elimination and really needs the support to prevent reintroduction of malaria from across the borders in West Timor. And so while this started out as an Indonesia-based project, it would be remiss of us to exclude Timor-Leste and not support them. So this is a slide that Dan has put together. It demonstrates the components of the project as well as the complexities of it. And so I won't delve into it. And I'll talk a little more about malaria challenges in each of the countries, as well as what we're going to be doing over the next 3 to 5 years to try to accelerate that elimination. I want to take this opportunity to thank, or at least acknowledge, APLMA and the Rotary Club from Kupang for the financial support they've provided for the first steps of this project. So just briefly, malaria in Timor-Leste, it's been an amazing response over the last decade, going from tens of thousands of cases down to none. In 2017, they started having no local transmission in the country. That lasted through the end of last year. And then we had a few cases that were identified in country. So we recognize that Timor-Leste needs support in the cross-border components, and we need to help strengthen the collaboration between NTT and Timor-Leste. They've established an MOU in 2019 to address the cross-border. Due to COVID, it wasn't really accomplished, and so we're looking at supporting the renewal of an MOU for cross-border collaboration. In NTT in general, there's been dramatic drop in malaria. Most of the districts are in elimination mode, with less than 1 case per 1,000 population annually. So that's all good news. But we have Sumba Island. There are 4 districts in Sumba Island that really create a challenge because 96% of all of the malaria in NTT is in Sumba Island. And so what this presents is this challenge of, we have Timor-Leste and some of the other districts very near elimination. And so that takes one approach that needs to be taken. And then we've got Sumba Island, which is still in malaria control mode because of the high incidence. So we kind of run the gamut of malaria endemicity between Timor-Leste and NTT. So getting into the project, what are the goals? Well, with Timor-Leste, we hope to support their WHO malaria certification by the end of 2025. That requires 3 years of malaria-free status, no internal transmission of malaria, and then WHO will certify them. And in doing this, we'll need to strengthen the cross-border collaboration with West Timor to prevent the reestablishment. But we also will need to advocate for sustainable domestic financing to support the continued malaria-free status. And this is something that was really just discussed, which is that as you get closer to elimination, you need to make sure the financial commitments remain until you get over the line and remove that threat. In NTT province, the goals are really to eliminate across the province by the end of 2026. And more specifically, West Timor trying to make it malaria-free by 2024. Well, what's our approach going to be? Well, the first step is really to undertake a scoping exercise and a gap analysis in both Timor-Leste and NTT to understand, what's going on, where are the gaps that need to be filled in order to accelerate the elimination in these 2 geographic entities. And so that will be starting in the next week or so, the data collection for that. Then what we do is we take the findings from that and we'll develop a work plan and a budget so that we can engage this coalition of partners, as Dan has talked about, from Australia, from international businesses, to help support and deliver, help support the governments and government agencies in delivering a malaria elimination, just to support the governments, and then to pull together, whether it be financing, whether it be technical support, private sector engagement, things like that really need to do. So we'll develop that work plan and the budget over the next 6 months to try to implement that later next year. And in doing so, we also need to not only look at the entities of Timor-Leste and NTT separately, but we need to strengthen the cross-border collaboration between the 2 countries.
Jeff, 2 minutes.
Yes, thank you. So this is, we've divided it into four work streams, Timor-Leste and West Timor. And of course, there'll be a cross-sectoral component there. We have pulled out Sumba Island as a separate work stream, and then the remaining 12 districts in NTT will compose the 4th work stream. We have just started, we'll start data collection next week, in the last 2 weeks, we've been having trainings and orientations for the data collectors and the workstream leads. So this is really starting to take shape. Over the next 3 months, we'll accomplish the data collection and analyses, draft a scoping report and a 3-year implementation plan to be vetted through the governments, keeping in mind that we're supporting the governments in their elimination efforts, with a plan to have a final scoping report and implementation plan by the end of March of next year. As Dan has mentioned, one of the key challenges is identifying the coalition of partners, especially the Australian partners who can help in NTT. We've got 6 partners now engaged, but we hope to engage the likes of WHO, the Global Fund, and then some of the Indonesian and international foundations and Australian businesses. Cheatham Salt and Nusa Tenggara Association are 2 that we're in contact with now. And then project implementation would probably take place after the middle of next year, where we would actually start rolling out the support to the governments for the accelerated elimination. And that will include a midterm review, which I think is very important to point out, so that we can then hone that as we move forward and plan for the final 2 years of the project. The benefits, in addition to making these countries malaria free and taking away that threat of malaria, we also are looking at strengthening disease surveillance and response systems, and that's hugely important in this pandemic era, as well as enhancing the information sharing and enhancing the cross-border cooperation. The challenges that we face right now are really identifying those potential implementation partners, and we certainly would call on anyone to help us support with that, or if you have ideas of who we could reach out to. And we have a small funding gap for this to support the scoping exercise. So I guess this is a pitch, funding pitch, if anybody is aware of somebody we could reach out to get a little bit of money. Just a list of the task force members. This is all pro bono and greatly respected, appreciated that everybody contributes their time. So with that, I'll stop. I know that was very fast, but Dan and I are happy to entertain any questions that you would have.
All righty, we only have about a minute for questions, but just if you could both comment on a bit of a conversation raging in the chat at the moment regarding why the private sector is so necessary in this particular project. There seems to be a why is the private sector, should it be responsible? Isn't this the role of government, etc.? If you could both speak to that in 20 seconds, that would be good.
I'll kick off. A core goal of XSPI is to demonstrate that cross-sector partnerships work and add value. Regardless of what your theory of change is, if it's shared value, then something's got to be in it for the private sector. Obviously, if it's collective impact, okay, because they see that this is the right thing to be doing, an important need. But it's proof of concept. From XSPI's point of view, it's both proof of concept, but it's also a matter of accessing resources, be it financial or, if you like, networks, whatever it might be.
Thank you. Jeff?
Yeah, just quickly, I think from a higher level, we need a great multi-sectoral approach. That means whole of government, whole of society. And I think that we're not going to accomplish elimination without a whole of society approach, engaging the community, engaging the private sector where we can, whether that be for financing or whether that be for in-kind support. So as we move forward, it's not only malaria, but it's other communicable diseases that will benefit from engaging private sector and building that component into their day-to-day routine. Thanks.
Fantastic. Thank you very much, Dan and Jeff. That was an outstanding presentation. We'll quickly move on into our next one, just so we're running on time. Our next speaker will be Ross Hutton. He's a malaria consultant for Public Health Solutions Australia. And he'll be talking about the National Strategic Plan in PNG and progress towards malaria elimination. Ross, please take it away.
Oh, good morning, everybody. First of all, everybody can hear me?
Yep, sure can.
That's great. Okay, thank you. All right. Well, as mentioned, I'm a public health consultant with a specialist in malaria. I've actually just returned from Papua New Guinea on Thursday, so I'm talking to you from my hotel quarantine cell in Brisbane Airport, where I'll be for the next 11 days or so. But I'm looking forward to sort of getting home, but it certainly was good to get back to Papua New Guinea again. So I was meant to be joined this morning by the program manager for the National Malaria Control Program, Mr. Leo Makita, but unfortunately he contacted me last night and he's had some other issues come up that he has to be engaged with today, so he wasn't available. But he just asked me if I could go through a couple of his slides to just present the National Strategic Plan, because it is the framework for which guides the program in Papua New Guinea. And then I'm going to talk about some of the specific activities that are going on in relation to the plan, and particularly in relation to the strategic framework, and how there's some Rotary input into many of these activities. So we'll just start with the National Strategic Plan that Mr. Makita had meant to talk about this morning. So just looking at the vision, obviously West Papua New Guinea signed up to the malaria-free objectives of 2030. The mission is to sort of alleviate poverty and malaria elimination, to particularly poverty and most marginalised populations. Some of the specific goals, and this is sort of getting down to the main focus of the program. So reducing morbidity and mortality, of course. So morbidity, the aims, and there's some very ambitious targets here. Currently, the national annual parasite incidence is sitting, we're not sure exactly which figure to go with, but it's around about between 108 and about 85 per thousand per year. So still very high, but they've set some goals to get down to 66% and then 25% by 2025. So you can see they're quite ambitious. Certainly reducing mortality is important, and we've gone from about 180 per thousand, 180 per 100,000, and aiming to sort of reduce down, well, really to zero, ideally. Looks like we have had some pretty good reduction in the last year or two. There's a specific mention of malaria elimination, particularly in the autonomous region of Bougainville by 2025. Bougainville is quite uniquely positioned with a very low malaria incidence for a range of reasons, both sort of population-wise, systems-wise, and ecology. So I'll just mention that now a little bit later on. So there's the figure for the cases in 2019. And ideally, when we get down to that malaria elimination in any of the subnational zones for 3 consecutive years. So there's some specific objectives. I won't read through them all in particular, but improvements in prevention with vector control, case management, behaviour change communication, surveillance, and that enabling environment. And then some of the priorities of the program, so just improving those case management and accelerate smart systems, which I'll talk a little bit about later on. Some reduction in sort of the 2 of the higher burden provinces, Madang and Morobo province in the north. And something we heard about yesterday from Carrie, the Vivax and the radical cure, and we heard from Professor Shanks as well on that. So I'll just mention those a little bit later. Okay, so I'll just, that's the strategy that we're all aiming to follow. And I'll just talk about some of the specific strategies that the country's got ongoing at the moment. So first of all, we're just talking about the data. So this was recently published data from the PNG Institute of Medical Research, looking at the prevalence. And you probably all know that we had a big spike in malaria in PNG in that 2016-17 period due to a range of issues. And Tim's going to talk about nets next. But probably a likelihood of combination of the issues with the quality of the mosquito nets. We also had a corresponding shortage of drugs and tests at that time as well. But good to see that malaria is actually has made a recovery, or sorry, the effort has made a recovery, and we're seeing a decline now in this latest survey period. These surveys are done every 3 years. They're a nationwide prevalence survey looking at probably about 7 or 8 communities in each province. randomly selected. So it's a good snapshot of how the country is doing, and it's measured every three years. Now, when we do talk about transmission and intensity, it's sort of along a continuum. You can see from that graph at the top there, looking from sort of high transmission, and we're all ultimately aiming to shift that graph to the right, to getting down to either low prevalence or low incidence. And we can be looking at this from like a national level or a subnational level, or even down to individual communities. So wherever a village or a community sits, it will sit somewhere along that line. And we need some targeted interventions to focus on the malaria at that particular transmission. The WHO has, in their global technical strategy, has given us a framework to work with, three pillars and supporting elements of the house there. So ensuring universal access to treatment and diagnosis and prevention. Pillar 1, accelerating efforts towards elimination. And most importantly, I feel at this time, is transforming malaria surveillance into a core intervention. I mean, we need to know where it is, who has it, in order that we can target our responses, and the supporting elements there of research that we heard about yesterday, and an enabling environment. I won't talk to this one in too much detail, but you can see on the left-hand side there, there's the 3 pillars. And then along that continuum, we've got a range of intervention strategies that we need to focus on. So, for example, all across the high, even to low, we need to make sure that treatment and testing is available. We need to make sure vector control is available. But then as we get down to those lower levels, we need to look at more focused interventions. And we heard from Professor Shanks yesterday that ultimately it's going to come down to that last parasite and household level interventions. So just one of the new strategies that's been introduced in PNG recently as a pilot that's expanding, and this comes under the heading of the universal access. So they've introduced a program of community malaria volunteers. This is a very common intervention in many countries, coming under the heading of the home management of malaria heading, but it's where you train up village people to do the RDT rapid tests and to provide basic treatment. And so there's now about 800 volunteers working in 7 provinces. And just recently checking the data, they've sort of done about, in the last 12 months, sort of up to about 50,000 tests and provided treatment for about 25,000 people. So this is across 7 provinces. It's really helping with the preventing malaria developing into a severe disease by treating it early. It keeps the visibility of malaria quite prominent in the communities, because everybody knows these people that have been trained. And even from a transmission point of view, and we heard yesterday about those gametes sites, the stage that can be of the parasite that's transmitted by the mosquito, they take about 7 to 10 days to develop once symptoms first start, particularly in Plasmodium falciparum. It's a much shorter period from Plasmodium vivax. But if that malaria can be treated early before those gametocytes have a chance to develop, and that blocks transmission. So it's a very useful strategy on many, many levels. Some of the challenges we're finding already is volunteer fatigue, and I won't get into the whole issue around volunteer versus some sort of a incentivized program, but we're certainly sort of seeing that already. We have some issues with the vivax cases not being able to be treated adequately because of the issues around primaquine treatment and G6PD testing. We need to get our data sorted so that it's emerged into the National Health Information System. And we do have a new National Health Plan cadre of a village malaria assistant coming on in Papua New Guinea, where that will be able to be included into that. Now, just looking at Pillar 3, I'll jump ahead to 3 and talking about surveillance. So we've had quite a revolutionary digitalization of the health information system with all of the health facilities. I think we've got about 4/5 now rolled out of a computer tablet, rolled out to them, where the data is entered directly into the tablet. And so it's almost real-time surveillance. So just with 7 pieces of data with drop-down menus, etc., all that information can be collected. From that, the system has a range of dashboards where we can monitor drug usage, drug shortages, the quality of the treatment, the species of malaria that's been diagnosed. It also linked to GIS mapping, so that we can, this is an example of looking at in New Ireland province, where there's looking for shortages of RDT tests. They're reported every month. All those green dots are health centres with good stocks. It's also used for mapping hotspots where the patients are coming from. So this is going to help with focusing in our interventions in certain areas. So as opposed to a one-size-fits-all strategy, we can start to really drill down, and this is sort of zooming in on that, so we can see from these individual villages where these cases are. So by various searches, we can search on a whole range of criteria. So this is looking at all patients with had an RDT with non-falciparum malaria, which is going to be likely Vivax for the last year, but we can narrow that down into all sorts of ranges for managing the interventions. But I'll just jump back to pillar 2. So accelerating effort towards elimination, and this is where we are sort of struggling a bit in Papua New Guinea now for a sort of range of reasons, but all the countries really should be aiming towards it. I'll just highlight a couple of the main issues that we're having problems with. So we need, although we have a strategy, but we're still yet to take those first steps to implementing some of these specific elimination strategies. And some of this is around issues around political commitment, the multi-sector support, and probably more importantly, just the collaboration and getting everybody together to focus in one effort at the right time. Certainly COVID has had a big impact in Papua New Guinea. It already has a very fragile health system, and this now COVID, and more particularly the COVID response, has really stretched the health system. So there's many issues around, I think Camilla from DFAT was referring to it yesterday, around even just getting health managers' attention. They're already stretched. It's a very thin system as far as management capacity, and so a lot of challenges there. So one project in New Ireland that we've been trying to push ahead, despite all of those challenges, this is New Ireland province up in the northeastern part of the country, and one particular local level government area called Tikana, where we've been trying to introduce sort of like a model of elimination interventions. So the population there is about 33,000 people. They've already got 20 of these community village treatment providers there. And the plan is to introduce some outreach response teams that will undertake some specific interventions in that area. So there's a new people with new training and new tools. We know that even though that area may have overall a high level of malaria, but by using the health information system, we can break it down into what's called ward levels, which is a collection of villages, probably around 1,500 to 2,000 people. And we can break it down into different levels of transmission. And so depending on the level of transmission, we can target our interventions more specifically. So we may want to introduce, for example, indoor residual spraying, and maybe eventually some expanded drug treatment blocking, as we mentioned yesterday, into some of these higher transmission areas. But in the very low transmission areas, introducing more targeted response, say just household level spraying, some larval source management, and maybe some household presumptive treatment, but important, like doing the case investigation, the case follow-up, and eventually the G6PD testing and adequate effective primaquine dosing. So we've had a bit of a struggle to get this project off the ground, just with the everything from travel restrictions to changes in the health managers in that particular area. So when I was up there just recently, we did try to get things moving along a little bit further. So this is a project that's sponsored by Rotary under the Rooks program. And so we do have some funding for it. And the provincial government has now agreed to put in some money towards it as well. But one of the issues, as mentioned earlier, that often this is not about money. It's about the political will. It's about the capacity of the local areas to implement. Because with this particular project, that we don't have any shortage of money to get going. Just on the broad, thank you very much. Just on the broader issue about elimination, Bougainville, as I mentioned, has been targeted for elimination by 2025 in the national strategy. Now, we're 1 year into it and we've not started yet, but there's been also some very challenging issues. I mean, there's travel restrictions going to Bougainville. Myself and Mr. Makita and the RAM, Dr. Munir from RAM in Port Moresby, we were meant to go there a couple of weeks ago, but we weren't able to actually get there. This is just a satellite image of where all the population live, and using the same health information system, we can break it down into various levels of transmission around the area. And we know it in Bougainville already. So 55% of the population only has an incidence of like 0 to 10, which is very, very low. And probably 3/4 of the population is even under 50. So there's a very good opportunity there to achieve elimination in the next few years in Bougainville. Just looking at how we will do that. So, I mean, we need an elimination task force for that area. We need to optimize and improve that surveillance system and establishing the team, expanding the volunteer program so that everyone has access to treatment, and then those strategic responses, targeted responses by the outreach team. So there still is a lot of challenges there, political focus, just the capacity within the health system itself. There could be some better coordination between some of the development partners, donors, and the national program, and especially as some of these new technologies that we heard about yesterday, and the processes of sort of fast tracking those as soundly as possible, and that translation of research into the implementation. So I guess I'm still a bit of a glass half full guy, a bit like that goldfish there. So I think there are a lot of positive opportunities. The private sector is doing a few things and could be greater involved. Of course, funding is going to always be important. As I said before, it's not always about the money, but we certainly can't do it without the money. So the RAM conference, I mean, this meeting itself is actually a very good boost in the upcoming ones. We've mentioned APLMA and APMN as advocacy groups who are really trying to help. There are some new technologies available now, some new ones around the corner. And at the bottom line, I think, is there's still a lot of good people out there doing a lot of good work, and including the work that Rotary is doing. So thank you very much. I'm happy to take a few questions and to stay in touch. So just thank you to RAM Australia and RAM PNG, of course, and the PNG National Department of Health for my last trip up there. So thanks very much.
Fantastic. Thank you, Ross. We have about 80 seconds for questions if anyone would like to kick it off. I'll just get you to stop sharing your screen as well, Ross, if you can, just so I can see everyone, just in case. So Peter's just asked, does elimination mean no human cases or the elimination of the parasite in the wild? If it's the latter, is there any knowledge on how to prevent re-emergence from the wild once the human population is disease-free?
Yeah, well, just quickly, so all mosquitoes are born free of disease, so it's got to be transmitted from one human to another. So that would mean somebody going away and picking it up, or somebody new coming in. And so yes, it can always be reintroduced, and so surveillance is a key strategy. And so to be certified malaria-free, there's got to be no local or no indigenous transmission for 3 years. So that defines the elimination. So.
Fantastic. Well, that's all we've got time for. Thank you very much, Ross. That was an outstanding presentation. I always love it when people use GIS maps, so I thoroughly enjoyed it.
Yes, I'm a bit of a thank you.
Oh, as am I. Fantastic. All righty. So we'll now move on. So we have PhD candidate Lincoln Timmerdauer talking to us about his overview of PhD research. So he's got 5 minutes for that, and then we'll follow it up. We'll have Tim Freeman, the program manager of RAM PNG, giving us an update on chasing malaria programs and RAM in PNG in general. So Lincoln, would you like to take it away? Do we know if he's here?
Just checking the list. He may not be here.
That's all righty. Tim Freeman, if you're here, would you like to begin your presentation, and we'll see if Lincoln joins us?
Yeah, good morning, everybody. Can you hear me?
We sure can.
Brilliant. Are you showing my presentation or am I doing it myself? Sorry, I don't know the protocol here.
That's right. If you're able to share your screen, Natanya, is that what we were going for?
Tim can share.
Yeah.
Okay, let me just give me 1 second.
Not a worry.
Can you see my screen or not?
We sure can.
Okay, let me just put it onto, trying to see if I can find it onto from the beginning. Let me just try and show it. Okay, can you see it all now?
Yep, looks good.
All right, good morning, everybody. Thank you very much for inviting me. This actually, for your information, is my 12th year to do this. So I'm very happy, and this is my annual engagement to come and talk to you about what we're doing at PNG. And this is a program that has been continually expanding from one year to the next. And every year, unfortunately for me, it gets bigger and bigger. Right, very quickly, we have a program that has 6 components. We have net distribution, health facility supervision, drug distribution. We have HMM that Ross just talked about. We also manage the finances of the Institute of Medical Research and NDOH for their small projects. And then from our side, we have 2 small programs, which is a school program, which RAM Australia has been funding, and a little elimination program we have here in Port Moresby. Very quickly, just to show you where we are up to, our funding has increased by around about $3 million from 2018 to 2020. It shows you where most of our funds come from. This year, for this 3-year period, we have about 37 million coming from the global funds. And then our next big donor is an organization called PNG STP, which operates in Western Province. So they're all, and then we have this small amount of money from ExxonMobil, and as I said last year, we had from RAM Australia. Just to quickly give you a background, RAM PNG started in 1997, selling nets to people, and as time went by, when the Global Fund came in 2004, RAM was asked to assist the government by importing nets from Vietnam and distributing them to the provinces from where the NDOH would distribute at a provincial level to the provinces. However, there was quite a lot of problems. In 2009, that's where RAM came in and asked to take over, coordinate the whole program. That's also when I came in, we'd take over the coordination of nets in the country. So very quickly, we have a 3-year program. This map looks a bit messy, but where we are, the reason is because we took on a historical program which was set out by the NDOH, which was often political in things. They used to go to different provinces and different places to keep everybody happy. Anyway, this year we are in all the areas which we've been in, all the areas which are light blue on this map. So at the moment we are in Madang Province, East Sepik, and we're just about hopefully to go to Western Province. That's North Fly and South Fly for those who know the area. This is very quickly the nets we distributed. We're up to 13.5 million nets as of June this year. And we also distribute nets to pregnant women. So put another 500,000 on there. So we're over 15 million nets in the last 12 years. So every year we do more than 1 million nets. So that just gives us the scale of operations. I just put this picture, just shows the kind of operational problems we have. Often the only way to get from one place to another is literally physically take them. And just to give you an example at the bottom, just showing that the road conditions in PNG are often awful and we struggle to get through. What are the advantages of this? We have a very consistent method of distribution of nets, which ensures, unlike most countries which have these mass campaigns, we just literally go from one province to another. What are our challenges? COVID has been a bit of a challenge. We had a whole team locked away for 14 days because one of the team members was found positive when they arrived in the province. We continually have problems with tribal fights, and 2 areas had to wait a year before we could even go into the district because of internal issues. We often have fights. We had a hijacking. Our biggest problem, ironically, is with the private sector. I'll just come back to this now. We often get on a boat and the boat owner will say, oh, we're not going for another 2 weeks. And we just had the same problem now. We've been getting large Russian helicopters we've been waiting for 5 weeks to get off the ground. So yes, we have many logistic challenges, poor airstrips and all the rest of it, but we get there. Our biggest challenge, however, I noticed somebody talking about funding. We don't have any funding for nets above 1,600 meters. We don't distribute above 2,000 meters, but this is a low area of anyway. Sorry, I'm getting tongue-tied here. Anyway, just to give you an example, this is just some pictures of helicopters. And sorry, I want to go back up here. These are the big Russian helicopters. This is from 4 years ago, but just as I'm talking now, these helicopters are working for us now in the same area. And we are now using these helicopters to reach some of the remotest areas in a district called Middle Ramu, where all the airstrips are basically being eaten up by pigs and you can't land aeroplanes. So the only way to reach them is with these massive helicopters. These helicopters, for your information, are actually about the same price as an aeroplane because they take 4 tons of nets and cost about 4 times the price of a small airplane. So they're actually good value for money when we can get them. Right, health supervision, we have what are called regional malaria coordinators. We have 12 of them, and their job is to visit every accessible health centre every 3 months. And when they go there, they do a number of jobs, which I'll come through in a minute. They have to ensure that all health centres have adequate stocks of malaria commodities. So we have been coordinating all distribution of RDTs and malaria drugs for the last since 2018. We ensure that all the commodities are properly recorded and utilised because we get in trouble when they go missing. The Global Fund wants us to pay for them. We ensure that testing and treatment of malaria is done correctly. And we also try and help with the health information system to make sure stuff is going on time. But we still have a major challenge. 40 to 50% of the cases are not recorded. You'll see here in 2020, we distributed 3 million RDTs. In fact, National Health Information System only records about 1.3 million of those being used. So really, about 40 to 50% of the commodities we distribute are never recorded in the system. We believe that most of this is coming from aid posts, but it's not clear. What are the problems? Communications to health centres are really difficult, and supplying these areas, particularly to areas we can't visit because we need aeroplanes to get there, can be very problematic. Good news is the ENHIS that Ross was talking about is now being installed in all the provinces. I think we've still got 5 to go. And our people are helping to make sure this system is being used. However, the reporting of the National Health System, while it's still very slow, appears to be getting better. Drug distribution, as I said, we visit every place every 3 months, and I'm very happy to say that in the last 8 years, there's been no major, since 2018, there's been no major shortage of drugs. Our biggest problem is that sometimes health centres don't tell us they've run out of drugs, and then they complain they haven't got any drugs. That's partly their fault as much as ours. Anyway, this shows you in 2020, the only district we are unable to visit is this one on the left-hand side called Telefomin. There is no roads into this area, and the only way you can reach this is by aeroplane, so we don't physically visit this, but every other district in the country, our staff go to. Sorry, this is just again showing the distributions from 2019-20. So I just got some of this, sorry, my apologies. Anyway, the overall drug distribution has been a huge success. And our biggest challenge at the moment, as we're having now, is that we have to supply the provinces. As you may not be aware, there's about 8 different road systems in PNG which don't link up. So the only effective way of getting stuff from one place to another is by aeroplanes. And at the moment, Air Niugini, our national carrier, is cancelling flights all over the place, and we're having huge problems getting drugs to some of the places. So we're now having to think about sending drugs 2 or 3 months in advance to make sure that they will get there on time. Anyway, these are just some pictures of how the drugs arrive. It's really quite amazing for me that often the drugs arrive in almost empty containers. You'll see on the right-hand side there. Anyway, we get these from drugs from overseas. We then store them in the national national health medical warehouses, and from there distribute them around the country. Okay, for the National Department of Health, we assist them with their finances. They coordinate all activities in the country. They carry out something known as therapeutic efficacy studies, i.e. they test the drugs around the country to make sure they're all right. And they also work very closely, as Ross pointed out, with the community-based programs, including the home management of malaria. I won't go into that since Ross mentioned it. So let me go on this one. I think we're at up to 9 provinces now, but this program I'm hoping will be doing well in the future. Here we have the school program, which has been done by, being sponsored by RAM Australia. We've been working with 7 or 8 schools. It's been a bit of a challenge this last year with COVID, but basically we tried to teach the school kids to go out and destroy all reading sites around the place. I'll show you some of the results in a minute, but alongside this, which has been very successful, we trained all the teachers in the schools to test and treat malaria in their schools. I'm very happy to say after a year and a half, this process is still going, and the school teachers have been very active, not only treating children in the schools, but also their local communities. So this aspect of the program has been very successful. You'll see here, there's a table at the bottom. It shows the prevalence rates we've done every May for the last 4 years. And we started this program because we were absolutely gobsmacked to find out that the prevalence of malaria was so high. If you look at the bottom line, you'll see that we had in one school, 64% of the pupils were carrying malaria parasites. And we've had very success. It's been going up and down, but you can see that in most schools here, generally the trend has been going downwards. Though we did have a relapse in the school called Kaviva, May 2020, for reasons I'm not sure. But overall, we are reducing malaria in these places. Sorry, I put these slides in for people to look at them later if they want to see more information. We have an elimination project to try and show that malaria is not transmitted in malaria in Port Moresby. And we have maps like this, which show all the cases, and we map all the cases in Port Moresby. Most of them are adults, and for as far as we know, most of the cases are actually being imported. So we have a girl working with us now, doctor, who goes around actually verifying all the cases of malaria in Port Moresby to see whether we have transmission. And I think in the last year, we've only actually identified 9 cases of malaria, which possibly have got malaria within the confines of Port Moresby. We also support the National Institute of Health. We've been supporting a stratification exercise, malaria resistance studies, and malaria indicator surveys. I think the important thing is here, this is the stratification above 2,000 meters. We don't distribute nets because we think there's no malaria here. But there's this area between 16 to 2,000 meters that people don't want to fund. Is where we think it's low light, it's low transmission, probably only Vivax, but we have no money from 2022-23 to cover these areas, which is a pity, because we've managed to find money in the past years to do this. Okay, Ross mentioned prevalence. So this is the prevalence surveys. Yes, it looks like in the last 3 years, malaria has gone down. However, if we look at the cases coming from the National Health Information System, malaria continues to go up. So we've got 2 sets of information which are actually basically contradicting each other. The bottom line is from 2006 down to 2015, malaria continued to tumble in PNG, and then since 2016, it's been going up. Now, maybe I'm hoping that the IMR data is correct and is going down in these places. Certainly, this is not reflected in the National Health Information System. What is good news, however, this looks at the inpatients and deaths. Despite malaria going up in the last 3 years, I'm very happy to say that inpatients and deaths have remained low. So this is a good sign, at least, that people are successful and that people are getting early treatments and avoiding the more severe aspects of malaria. This is just a quick map by province. I won't go into detail on this, but basically you'll see in this map that many places by 2015, we had very low malaria, particularly somewhere like Sandaun, which is on the border with Indonesia. 2015 had incredibly low malaria, now has a very high. Now, this is the part where I really want to come to and make a big noise. In 2018, IMR started testing some of our nets and discovered they weren't working. And we had an exercise, and we went around the whole country collecting nets which were still not in their packets. And we managed to collect samples from 2007 to 2019. And when we tested them, we found that nets up to 2012 were working extremely well. But then from 2013 onwards, none of the nets were working particularly well. And these are the lines. You'll see that 80% is the cutoff. This shows you the 24-hour mortality. So when you test the nets, put mosquitoes on them, we found all the nets up to 2012 were killing everything that touched them. But after this, malaria, the nets were not working. So from this, we stopped taking, these are permanets from Vestergaard Fransen. We stopped any further nets from 2019 because, for me at least, the major reason why we've had a upsurge in malaria is because the nets were not working in anywhere near as well before. Before 2012, for instance, we could almost expect a net to last 5 or 6 years in terms of insecticide. After this, we were finding the nets, even 1 or 2 years old, were not having any impact whatsoever or not killing any mosquitoes. So since 2020, we've been distributing 4 other types of nets. So we've had nets called Safe Net, Interceptor, York, and the Royal Sentry. However, of the 4, when we tested them, we actually only found that one of them seemed to be really good, and this was the Royal Sentry net, which we distributed. And I'll show you here, these are 2 graphs from the provinces. This shows this province I'm showing you, the west of the country. When we started putting nets in, we got an immediate drop down at the beginning, end of last year, and we've had the lowest Q2 ratings. However, people are saying, oh, this is COVID because people are not going to health centres, so this still remains, but it looks very promising. More surprising is that in Millen Bay, we distribute another net called SafeNet, and you'll see that where Permanet was distributed in 2017, malaria went down for 2 years, but then the following year, it shot straight up again. You see with SafeNet, much to my surprise, even though it didn't test well in the laboratory, malaria in Q1 of 2021 is the lowest level it's been for the last 5 years. So I am praying that perhaps this SafeNet is a better net than we originally gave it credence for. So we are doing a lot of testing to see if we can find a net that is working. So sorry, so let me go back to this. Yeah, 2 minutes. Okay.
2 minutes.
2 minutes, thanks. Our major challenge, and this is really messy, is that we have no hope of malaria elimination in this country until we sort out our nets. The nets at the moment, we do not know which are good quality and which are not. We're working very closely with IMR to try and identify. Other things, very quickly to finish off, we've had communication campaigns, we've had pamphlets produced, and these are some examples of flip charts. I'm sure Jenny will say, please send me some flip charts, which I'm sure we can do. This is just to show you the number of staff. We had 20 staff in 2012. We're now up to 130 staff, so we continually go up. So the 2021 program is, yes, we're continuing as normal. We have all the things I mentioned continuing. And I said, really, our major challenge is making sure that we have all the nets, we have all the, we could get good nets for the coming years. So this, as I always show this picture, it's still my favorite picture, showing the realities of getting nets. This is on the border with Indonesia, poor old lady with a baby carrying nets into her villages. That's the only way we can get there. So this is our team for this year. That's me sitting in the middle of it with all the staff here. We have a fantastic team and I'm really proud of them. I just wish we could get malaria down because at the moment, I'm very despondent. In the last 5 years, all I've done is seen it go up. Thank you very much indeed. I think that's it. And sorry for rushing. You can get, I put the more details there so you can share the presentation and people can look at this in more detail if they need to. Thanks.
Fantastic. Thank you, Tim. Just before we go to questions, we'll try Lincoln. Are you able to try give your presentation? Perhaps not. Alrighty, so we might go to some questions. I appreciate it. I apologize if I can't get to your questions. There's lots of chats going on at the moment. So Anthony Maple had a question regarding children's education and awareness of malaria in PNG, and mentions that often the young people in the family are the only ones who are literate. Could you talk a bit more about the importance of engaging young people with the fight for malaria in Papua New Guinea?
Yeah, the program we've tried is that, and it's something I've been doing for the last 20 years in different countries, is that malaria is often caught by ignorance and most malaria can be easily prevented in very many ways. And so we're targeting the children. So I call this education for living, that they try and change their behavior, which protects them for the rest of their lives. And obviously through changing their behavior, hopefully they change the behavior of their parents and the rest of the family. So this is a very important component. And for the most part, education in the third world, or sorry, the developing world, is really targeted on passing exams rather than surviving malaria.
Awesome, thank you. Kerr Wilshire's asked, how do we go with correct storage of the drugs, expiry dates, and the impact and effectiveness of those drugs?
Oh, well, we have a fantastic team here. We use a system called M-Supply. All the drugs in the country are recorded where they are, when their expiry dates, the batch numbers, etc. So we're always keeping an eye on when they run out. Yes, we can't control if drugs go to a health centre and the health centre doesn't use them, But with our visits, we can, for a good part, keep an eye on this as well. The only places we have no control of are other places in the mountains where we don't go to, where they can only reach by aeroplanes. So there are some limits, but generally at a central level, we have no issues at all.
Peter Beatles asked, why did the net stop working in 2015? What was the reason for the decline in efficacy?
No, it's actually 2012. We believe that the manufacturers, without telling us, changed the binder of the net. The binder is the glue that holds the insecticide onto the net. And we believe there were some fundamental changes to the nets in 2013. So we didn't actually see the knock-on effects of this in 2015. And I'm very sad to say that we reported this to Global Fund and to WHO, and they're all dragging their heels. So we had a kind of bit of an international fight on this, because one of the things I want to say is this is not a problem just for PNG. If you look at many countries in Africa, they have a very similar picture of where malaria has started to go up again. Now in Africa, they blame this on insecticide resistance, which we don't have in PNG, but we think, and personally I think the bigger problem is the quality of nets rather than the insecticide resistance. So we're fighting with Global Fund and WHO to take this more seriously, because we continue, the global community continues to pay billions of dollars in new nets, which for me, from judging by our own experience in PNG, are not very good.
Fantastic. I think that's probably all we've got time for. Tim, if I could get you to stop sharing your screen, is that all right?
Yep, just give me a second. I can work out how to do it. Stop share. That's it.
Perfect. Thank you so much, Tim. That was an outstanding presentation on the current fight in PNG. We'll try in a few minutes, just in case we can get Lincoln back. We'll move straight on to Dr. Edgar Pollard from the WHO of Solomon Islands, who'll talk about active case detection pilot project in the Solomon Islands. Edgar, are you right to take it away?
Yes. I'll just share my screen. That's okay. Okay, can everyone see that?
We can see and hear you perfectly.
Yes, excellent.
Okay, great. Yeah, good morning, everyone. My name's Edgar. I'd just like to note that I was a previous RAM scholar up in James Cook University, graduated or finished off in 2019. Yeah, so I see a lot of familiar faces or names in the participants list. Good to, I guess, see you all again virtually. I'm sure it'd be good sometime in the future to catch up again. So now I'm back here in the Solomon Islands, and I'm working for WHO, supporting the malaria program, which is good, interesting. So working with the Ministry of Health. So this is a short proposed project that we're going to be starting next year. Just over the past month, we finally got sort of the green light approval from Ministry of Health and Honiara City Council, and it's going to be funded by RAM Solomon Islands and RAM Australia, sort of working on this. So just for those who don't know, Honiara is the capital city of the Solomon Islands. So just a bit of background on what the situation is currently like in the Solomon Islands. So for the past over 20 years, malaria's generally been showing a positive story. However, for the past 5 years, I think maybe similar to PNG, as the trend has sort of gone in the other way that we don't want it to go. And this is for various factors, which I'll touch on the next slide. And so just want you to note that this is based on passive case detection data. So data that's coming through public government clinics. so it's not quite perfect. So what are the challenges that we're having? So there has been a decrease in funding since 2015, but I just want to note that as of this year, Global Fund has increased investment into the Solomon Islands. So hopefully we should see a change in that graph over the next couple of years. Human resources is still a challenge here in the Solomon Islands. There hasn't been much investment into malaria workers at various levels of the country. So that is an added challenge as the country continues to grow with the increased population. There's been some reform around 2015. So the Ministry of Health has moved into an integrated model. In the past, it was sort of called a Ministry of Malaria, where the malaria program managed everything from drugs to community awareness to outreach, everything. However, now with the new integration, drug management and commodities is managed by the National Medical Stores. Community outreach and awareness is managed by the Health Promotion Division. So there's a lot of challenges there. There's a challenge of reporting. One of the reasons with the increase was also there was better reporting. However, we're still finding that there's a lot of gaps with reporting of data in the country. For example, all the private clinics in Honiara, none of their data is collected to any central database. We have ongoing challenges with shortages with malaria commodities such as drugs and RDTs, especially out in rural areas, that's a big problem. And with RDT shortages, there's a lot of what we're calling presumptive case recording and presumptive treatment. So people are just given malaria treatment based on just symptoms that the nurse can identify. There's also a bit of asymptomatic malaria. So I guess with the whole, now with the COVID language, I guess people are aware of what asymptomatic means. People living in communities who are carriers of malaria, but not, I guess, sick or showing symptoms. So that they are contributing to transmission. Now in the Solomon Islands, Plasmodium vivax PV malaria is the dominant. So about 2/3 of the malaria is now PV. And one of the issues with PV, as you probably have heard, is relapse. So through the parasite hiding in the liver and coming out again. And one of the challenges with that is primaquine treatment, even though it's recommended in the national treatment guidelines, it's not being practiced so much. People aren't giving treatment. And I guess this is also due to a lack of G6PD testing that's happening throughout the country. So what's the rationale behind what we are planning to do? So malaria in Honiara is key to malaria in the Solomon Islands. Honiara is basically, I guess, the melting point or the center point of Honiara. It has a very high incidence rate. And basically everyone comes to Honiara and everyone goes out of Honiara. So if we're able to reduce the burden in malaria, that should translate to the burden in other provinces. We need to start re-educating people around malaria. Now people see malaria just as, something like a cold or a flu. You get malaria, you get tested and you treat it. And no one really thinks that malaria is something we can eliminate. So there needs to be an investment into getting people aware and thinking and talking about malaria. We need to move away from the business as usual approach. Basically, the front line of malaria, the malaria battle in the Solomon Islands is just bed net distributions. So we're looking at trying something different. And there's also high unemployment in the Solomon Islands and even graduates coming out of university from the region and even from Australia and New Zealand struggling to get work. So this is sort of some of the background behind what we're trying to do here. So exactly what do we propose? What's the plan? We want to have we're going to have a team based at a clinic to serve the catchment area of that clinic in Honiara. So Honiara has 8 clinics and sort of divided into 8 catchment areas. So we just want to focus on one of them to start off with for 6 months. So this is just going to be a 6 months project next year, beginning in January down to June, July. So they will have a fortnightly schedule to visit house to house, and they will be fever hunting, so with thermometers, testing people in houses, and then and then testing, and those that are positive, treating them, and not just treating, but following up treatment to ensure that people do complete their doses. Another aspect of this is household mapping, so mapping all households within the community, so that we can try and identify hotspots to see patterns of where malaria is happening, and also having a relationship with these communities to be able to share awareness, outreach, help them with community programs to make sure they're using bed nets, but also maybe clearing of larval sites. This is a map of sort of the catchment area. So we've found 11 localities, or I guess suburbs, along the Matanuka River, which is, if you've been to Honiara, the central river in the city. We've estimated a rough population of around 10,000 people and around 1,500 households. So who's behind all this? We have an advisory oversight or planning committee that's involved of RAM Australia, the National Vector-Borne Disease Control Program, WHO Regional Office, and the Honiara City Provincial Health Director. We then have a one layer down, sort of a coordination level, which involve those at the clinic, those at Honiara Malaria Program, those in WHO Solomon Islands, which is basically myself, and those in RAM Solomon Islands. And then from there, we'll have sort of the team, the staff or the workers. So what's the innovation here? What's special? So I guess the first thing is we have good collaboration here. We have people from, we've got WHO, we've got Ministry of Health, and we've got RAM, both Solomon Islands and Australia, and also sort of the Honiara City Council, all sort of working together, coming together behind us. It's been a little challenging to get everybody around the same table, but it's been, we've got there. We want to be active versus passive. So currently everything that's happening in the country now is passive, and we're waiting for cases to come in, but we want to try a model where we are active and going out and trying to find the cases in the communities. So I say fever hunting. Direct observed treatment, so in observing high treatment compliance to ensure that people are completing their medicine. And we want to introduce G6PD testing so that we can be giving out Primacan to people with Vivax, so that we can clear out and try to reduce relapses from happening. And I guess we'll be also having a mapping database so that we can, map cases, communities, households, and use that data for planning with Honiara City Council. And what are we building towards for the future? There's talk about having a RORCS, a global grant, maybe. But then also coming up with a model for Honiara to propose to other donors or funders. So we want to push this out to all catchments of Honiara and to continue for an extended period of time. If we can get this to work and show that we are treating people and bringing malaria down in the city. Yeah, thank you, Tomas. Yeah, happy to have a chat, take any questions that have come up. Thanks.
Awesome. Thank you so much, Edgar. That was an outstanding presentation. Do we have any questions, anyone? I might get the ball rolling then. I just had a quick question about like follow-up treatments. Is that much of an issue in the Solomon Islands? You know, people being diagnosed with the disease and then going through all the treatment processes. Are you having issues with that? And how do you sort of combat resistance to being treated, I guess?
Yeah, I think especially with Primacan, which is it's a long treatment, 14 days, and I guess you're not feeling too sick once you've gone through the first few days. So especially in our communities, people are, we need to be helping them, talking with them, increased education. Yeah. And what was the second part of the question?
Oh, you've answered both parts. That's all good.
Okay. Yeah.
So Peter Beadle's got a question. So it says it seems like a lot of work for one disease. So are you getting more than just malaria done when you do these visits? Are they addressing other health concerns and issues in households?
Yeah. So with discussions with Honiara City health team, we're going to start with malaria, but there is an idea to sort of build upon this and maybe add other people and other diseases, especially something like NCDs, which is a really big problem here as well, and trying to
yeah. So it's evolving into a broader public response.
Yes, and one of the concepts we're discussing is using malaria as an indicator of which communities we should be investing more people and time and resources into.
Awesome. Jenny's just got a point. If you could just talk about the shortage of anti-malarials, why and where are the bottlenecks, and why are communities having to pay for medications?
Yeah, I mean, basically, Global Fund is funding enough, I'd say. I mean, it's funding all of the anti-malarial medications for the Solomon Islands. There may be an argument to say that some of our population estimates may be off a bit. We had a census in 2019, but the data still hasn't been released yet. Yeah, I guess there's just, we don't have the answers. We're trying to investigate, and they are meant to be using M-Supply. There's complaints of it not working. Data connectivity and communication between those in communities and the rural levels and sort of coming up is a big challenge. And one thing also is getting, I guess, nurses to understand stock management properly. A case that I heard is that there was a clinic where the nurse waited until the medication was finished before placing the order for the next batch. So sort of having understanding buffers and just, there's lots of things. And there's also sort of, leakages, I guess, corruption and sort of drugs being sold to the private sector. And there's all that happening as well.
Yeah. Well, Tom asks a question like, what percentage of malaria cases are treated in private clinics compared to public clinics? And how much underreporting is happening, if you've got any idea of that?
Yeah, so the first question, we don't know. In Honiara, I mean, just personally, nearly all of my acquaintances go to private facilities, so we have pharmacies and doctors who do it, you have to pay as opposed to going to the clinics, which is free. However, clinics have a long wait time, and it's it's much quicker to go to a private. We are looking at how to incorporate data reporting from private clinics next year in a different project. So hopefully we'll be able to answer that question soon. And in terms of underreporting, just based on data for last year, so only about nationwide, around 90% of clinics reported sort of information coming to the National Health Information System. So there's that 10%, and some provinces drop down to even sort of only 70% reporting. So you have the gap of just not reporting and very delayed reporting. So some provinces even months before the data coming in, and then you have sort of also the private sectors. I think substantial gaps there, which may paint an even darker picture.
All righty, thank you very much, Edgar. Does anyone else have any questions before we finish up? Nope, all good. All righty, thank you very much. That was a very important and valuable overview of what's happening in the Solomon Islands. Thank you, Edgar. We'll now move on to our next speakers. So we have Dr. Tessa Knox, my apologies, and Wesley Donald. So Wesley's the manager of Vanuatu Malaria and Vector-Borne Diseases Program, and Dr. Tessa Knox is a WHO technical advisor in Vanuatu. So they'll be talking about an update on the progress towards eliminating malaria in Vanuatu. Take it away.
Thank you very much. Happy Sunday, everyone. Could you just give me a thumbs up if you can hear me okay?
We can hear and see everything perfectly.
And see the screen?
Yep.
Okay, great. Excellent. Well, Edgar's a bit of a hard act to follow along from, but I'm glad that we are, because in fact, a lot of the challenges and a lot of the settings that we have in Vanuatu are very similar to Solomon Islands. So similar issues with primaquine, similar issues with commodity management, similar issues with community engagement. So we're actually not going into a lot of the detail of that today because Edgar's done such a good job. What we're going to do is give you a bit of context of Vanuatu, just to show you why it is a really interesting, really unique place. And it goes beyond malaria, but I thought this would be an interesting lead into what Wesley will then take over from and present on, which is just some of the really key areas that we hope to focus on to move towards elimination for Vanuatu. So what I thought I'd start with was a bit of an indication of what the context is in Vanuatu. So it is a lower middle income country. It actually graduated to lower middle income late last year. There's a very high dependence on tourism and the Pacific Labour Mobility Initiatives with Australia and New Zealand. So I think this high dependence on tourism might be something that's a little bit different from Solomon's, because I think they don't have as much of a dependence. But this has meant that Vanuatu has been very affected by the COVID pandemic and the closures of a lot of the international travel routes. However, it's been quite resilient throughout this challenge because 80% of the population are actually rural. So there's been a lot of dependence on local production and local farming. There are 83 islands that comprise Vanuatu. I think over 50 of these are inhabited, and it's the most linguistically diverse country in the world per capita, with 138 Indigenous languages. For anyone who's been here, who's visited, which I think will be quite a few of you, you would have realized that custom or culture and tradition is interwoven into every aspect of society. It's very prominent in politics as well. And it's a fascinating and quite complicated and complex context in which to operate, but it is something that really does need to be considered in malaria programming and other communicable disease and health programming and health initiatives. There are Christian principles espoused in the National Sustainable Development Plan. Vanuatu has been independent now for 41 years. It was co-administered by France and the UK up until 1980 when it gained independence. And there are 3 official languages. Bislama is a lingua franca, and then we have French and English as well. So this is just to show you how diverse and sort of complex the context is in Vanuatu. In terms of governance, the government is run by the Prime Minister and the Council of Ministers. The advisors to the Parliament are the Council of Chiefs. There are community leaders, chiefs, churches, women and youth groups that are very prominent as well and have a lot of say in a lot of the decisions that are made at subnational level. One of the really important things to consider about Vanuatu is that it is the winner of the most natural disaster prone country in the world award for 2020. So very, very susceptible to cyclones, earthquakes, a lot of volcanic activity, water influxes that are associated with these weather systems as well. So when we're thinking about malaria programming, we really need to make sure we build in the resilience and the disaster planning to be able to weather these hazards. In terms of the Ministry of Health technical capacity, there is good technical capacity. The leadership changes do complicate things as well. At the moment, we have a Director General and all 3 directors that are acting appointments. So none of them are the permanent appointments, which can interrupt a little bit the continuity of some of the activities that we're trying to put in place and the advocacy that we've done in the past. The technical leads in the ministry are all extremely busy. They have very wide portfolios. There's good continuity in the staffing, but there's quite a heavy workload. And a lot of those staff have been repurposed or reassigned to work on COVID. And there's also a lot of frequent travel from the national program down to the provinces, which can make things a little bit difficult to maintain some of the work that's going on, a lot of the technical work and the guidance that's being developed. Overall, staffing is relatively limited in the Ministry of Health. There's a lot of vacant positions on the structure, and we're finding that it's really hard to get qualified people into those positions as well. So in terms of malaria elimination, which we're all here to hear about, there's been very strong development partner support in the past from 2004 up until around 2014 and 15. There was really a huge amount of support that was coming to Vanuatu, but this was reduced quite significantly due to some grant administration issues. What we're seeing now, though, is there's renewed interest, and this is, in the opportunities column, but we've had renewed interest in 2021-22 by Global Fund and by Rotarians Against Malaria and Rotary as well. And Wesley will go into some more detail on this. There are challenges with staff, there are challenges with financing, and again, COVID is interrupting activities because a lot of the malaria staff are very good at the community engagement side of things. So they've really been heavily involved in this in Port Vila and around in all the provinces, as well now as the vaccine rollout. We do know elimination requires intensive activities and documentation. This is a massive consideration. We need to be getting everything on paper so that when we do apply for the certification of malaria-free status to WHO, we have years and years of proper documents to be able to support that application. And of course, as mentioned in the context, we do need locally tailored information, education, communication, behaviour change communication initiatives. So this is quite resource and labour intensive to develop and to deploy. The good thing is we have a very committed leadership in the Ministry of Health and above at prime ministerial level as well. They really want to show a win. They really want to achieve malaria elimination, and they want it done soon, which is fantastic. Like I mentioned, we have renewed funding interest. We have some opportunities we put in place now for surge staffing towards the end game, towards elimination. Wesley's going to talk a little bit more about these, just to mention that there's a WHO Stop Malaria consultant who should be deployed, hasn't been able to get into the country because of the border restrictions, but we're hoping will be with us from January or February next year. One thing that Vanuatu does have as well is an excellent example from Tafia province of successful elimination. This was using the community structures that I spoke about before. And so this really does present a good example of something that we can build on and roll out to other provinces, which has started and has been ongoing for a number of years now. But this is a case study that was done 2 years ago to really work out what was the reason for the success in Tafia. And this really was nothing new, nothing novel, nothing exciting, but just doing good programming, good delivery, doing it well, monitoring it to see where we can make any changes, making sure the funds are in place, the staffing was in place. So nothing novel and new, but nothing easy as well, given all of the systems challenges that we do have in the country. So I'll hand over to Wesley now to update you on the status. Thank you.
Sorry. Hi, everyone. I'm Wesley Donald. I'm actually the program manager for the program. And thank you, Tessa, for taking us on the introductory part. Yes, I think Tessa has actually mentioned a lot in terms of the governance and then the opportunities, the challenges that the country has actually gone through so far. Despite of this, I think the country has actually done a lot of progress so far since 2010. And up to 2020, which was last year. So I think around last year, the country actually reported around just about 500 cases in which we have more of these cases actually Plasmodium vivax. Otherwise, there has been no death been reported so far since 2012, which is a good news for the country. And I think we still try as much as possible to maintain that. And as you've seen on the trend, we tend to have fluctuations in terms of the annual parasite incidence, or API. So if you look at 2010, the cases tends to be high. It's just because of the beginning of the rollout of the RDT in 2010. So 2009, sorry. And that's where we have more of the cases, hidden cases being detected. And then you have high cases in 2010. And then we have high coverage of bed nets, and then we have a effective treatment, and then that results in a continuous decline from 2010 until we suddenly been struck by a tropical cyclone in 2015, and it's a Category 5 cyclone, and then we have also that makes us increase in API in 2016. Otherwise, with the continuous progress so far, from 2010 up to 20, despite of the Category 5 cyclones and even COVID-19 disruptions, as Dr. Tessa has mentioned, there is actually a significant decline in the number of cases so far. So as from January up to September this year, we had Malaria Elimination meeting being conducted where we involve all the malaria information officers and also the malaria provincial malaria supervisors. And based on the information that they provided, it showed that there's a remarkable reductions as compared to the first 9 months of last year. So approximately there's 30% in terms of the reductions. Otherwise, according to our National Malaria Elimination Strategy for the next 5 years, that's for 2021 up to 2026, we should be able to achieve that elimination target by 2023, and then we hold on to that for the next 3 years, and then we certify elimination in the country by 2026. And I think there is still some challenges, like Tessa was mentioning, and I think there's similar examples to PNG and even in the Solomons, whereby we still have some last pockets of cases and transmissions going in some of the areas. And I think here in Vanuatu, 2 are the most islands that still have high number of cases is in Santo, which is in Sama province, and also in Malamba, which is the Molecular Island. And in Santo, it's just because of the people actually moving around most of the time, and then there's some cases where it's really hard to reach. It's because of the mountainous terrains and also the geographical locations of the place. Tessa, can you move to the next slide? Okay, so otherwise one of the interventions as part of the vector control strategies that the Ministry of Health is actually trying to adopt, in which this has already been conducted in the Tafea province from 2009 up to 2011, is the targeted indoor residual spray, or in short it's IRS. So this intervention has proved a significant effect in terms of reducing the number of cases by actually reducing the vector density and all this. So the ministry is actually working together with the RAM, or Rotary Against Malaria, to try and roll these activities to be targeted in some of the remaining active foci, especially in Cento and in molecular. So I think with that, RAM has actually supported the program through the Ministry of Health in actually hiring a consultant that actually has provided the training to the trainers, and they've also provided the training materials to the trainers as well. And I think there was some of, and followed to that, we already received the spray cans from, with the support from RAM, it's already 10, and also the insecticides actually underway to reach the country. And as part of the IRS, we will normally have to conduct this baseline mapping to actually to determine the number of houses that needs to be sprayed, and then to be able to know how much in terms of the coverage and all this. So I think this has already been it's being planned for, and we're in the process of actually trying to conduct this activity by early next year. So again, as Tessa was saying, with the time that we have, and then the involvement of the national and the provincial staffs with this COVID-19 vaccination communications and advocacy, and also the vaccine rollout. So it actually delays some of the program activities that needs to be carried out this year. So we tend to try and move some of this to early next year as soon as possible. Okay, I think just similar to one of the presidents, I think from PNG, they were mentioning about his support officers. So in Vanuatu, I think we've actually experienced this is part of the TAFEA case study model, in which we're trying to, as much as possible, to have some shared support in terms of recruiting additional support volunteers, such as the malaria elimination officers. So this was based on the TAFEA model to try and help us to try and trace, assist us in the case, conducting case investigations in continuous transmission area, and also to assist in direct observed treatment, DOTS, and also to be help out in the community engagement and all this. So during the planning, we already have, it's going to be supported through Global Fund, and also there's going to be a few of them that's going to be supported through RAM, a total of 10 altogether, and they're supposed to become on board early of next year, from 2022 up to 2023. So I think from the experience, they've actually helped us a lot in driving the program towards eliminations, because they're actually the ones that actually live in the community. They know the community the best, and then they'll be able to work together with the provincial staff in trying to, as much as possible, to conduct case investigations and all this. And one of the things that they will actually help us a lot is trying to provide help assist in the in terms of the treatment under DOTS. So I think this is one of the things.
2 minutes, Wesley.
Yeah. So what? Yeah. So the next thing is in terms of the advocacy and the engagement. We were really keen from the support that's going to be provided by the RAM. They will actually help us to provide us some support towards communication and advocacy and all this. So one of the main events that we think that it can actually support is this World Malaria Day in each province, and where the theme will be kicking out malaria. So that's going to be the theme of the World Malaria Day. It's going to be happening in the 6 provinces. And we've already discussed it with the provincial malaria supervisors, and they've taken note of that. And there will be some prizes that's going to be given out during that time. So that will also be a good opportunity to provide communications, awareness, and all this at the time of the event for all the provinces for next year. So I think in terms of the conclusion, otherwise we have, as I've already mentioned, we have this national strategic plan for malaria, and it actually states out clearly the goal, the visions, and then the strategic objectives. And as I've mentioned, I think one of the good things is that there's already been clear indication that there will be a reduction in the number of cases as of this year. So I think this year we've reported from January to September, just above 150, but less than 200 cases. So I think that we'll actually have, be reaching our target for this year is to achieve less than 1 per 1,000 populations. So that's one of the promising things that we've actually looked forward with that. Again, it depends on whatever situations that we'll be going through for the next 1 or 2 weeks up to December. As Tessa was saying, we are prone to disaster and all these cyclones. We do not know what will happen in the next few months, but we believe we'll be able to maintain this from now at the end of this year. Otherwise, there's this continuous partner support that is essential to set staffing and intensify the activities. So we have the support from the Global Fund that is actually funding the program for conducting some of the activities. We also have the support from WHO in assisting some of our staffs under the support special service agreement, SSA contracts. And then we have this also other support from the RAM. I think just to conclude for that, we would like to say thank you to the Rotary clubs in Australia, in New Zealand, and Global Malaria Grant, and even the RAM for actually supporting us thus far. I think from our end, thank you so much for listening. Thank you, Thomas.
Awesome. Thank you so much, Tessa and Wesley. That was a fantastic presentation on the fight against malaria in Vanuatu. Does anyone have any questions? We have about 30 seconds if you want to sneak one in. Alrighty. And unfortunately, we weren't able to hear from Lincoln today. He just had some technical issues, but I think he was here listening along with us, so it was good to have him. Thank you very much, everyone. That concludes our list of speakers for the day. It was a very, very good series of speakers, and I will not delay further. I will hand this over to Dr. Jenny Kerrison for some closing remarks and some announcements.
Thank you, Sean. I'd like to thank everyone. The speakers today were amazing. I just love the practical application and listening to Edgar, I felt really sad. But listening to Tessa and Wesley, that was just great. Yep. Anyway, without much more, I should just hand over to Dr. Bruce Anderson. Dr. Bruce will be, I'm stepping down end of June. And Dr. Bruce will step up. I hope to still continue in my role to advise RAM and possibly take charge of NTT province in Indonesia. The challenge is to get that $2 million program of scale, everyone. I'm not going to leave RAM, so you'll have to carry me out perhaps. But we've got to get that grant happening. So anyway, over to Dr. Bruce. Thank you very much, everyone.
Well, okay, look, thank you, Jenny. Thank you for everybody still on the screen. We've had a couple of days of just remarkably instructive talks from all of the different people. We've gone everywhere from the highlands of New Guinea out into the Pacific and into the Mekong sub-region. And I think if anybody came to this without a true appreciation of the fight ahead of us for malaria, they'd be well and truly brought up to speed now. So there's all of the very, very good grassroots work going on. We've heard a lot about the challenges. We've heard about some of the promising things on the horizon. and the local vaccine candidate is mentioned amongst that. What is clear is that from very, very limited financial resources, but with a lot of very heavy input of time and energy from people such as Jenny and the rest of the organising team and the rest of the RAM committee, we've actually pulled together a pretty impressive conference, and I think all goes well. I just encourage everybody to think about our next conference in this series, which will be held about the same time next year, and that will be in Brisbane. At the very least, we are hoping that some of that will be absolutely live and in person, COVID permitting, but we'll also reserve the right to patch on in really good key speakers by Zoom or other means if necessary, to make sure that that we have a great stimulating conference such as this one has been. The next thing to say about next year, and the reason we want to have it in person, we really do value within Rotary those personal interactions, the fellowship face-to-face, the chats over coffee, which is where a lot of the good ideas actually come from. So in terms of where we're going with RAM, just to fill you in, I'm going to be putting up my hand to take over the RAM management role from Jenny. Jenny will stay on and give us some support. Ivor Harris, who I think is on the screen, is going to take over chairing the RAM Scientific Committee that I'm currently chairing. And we also have the Malaria Congress in Melbourne 2 years, in 1993, just before the Rotary International Convention. And we are already working very hard to involve all of the local players in the malaria space here in Australia, including the academic researchers from all of the notable institutions, to really highlight the commitment to elimination of malaria in our region that is being driven by all of the malaria players in Australia. So all I can say is it's been a great conference. What comes through clearly is all of the partnerships that are being established at very, very high international levels, at very, very low local levels, and within each country. With partnerships, we can all achieve a lot more than we can with individual localised efforts. So I'd encourage everybody, stay in touch with everybody, keep following the various links that have been put in the chat room, and we will be looking, as COVID allows us, to get back to meeting a lot more in and around in person with our Rotary clubs. It's one of the ways that we can generate local money, which we need to generate to support PhD students and those sorts of things. But the partnerships will enable us to get those bigger amounts of money to progress towards elimination. And nobody is in any doubt that we've got quite a challenge ahead of us. But we'll put all shoulders to the wheel, and we should get there. So thanks everybody for your attendance. I'd like to note that as RAM in Australia is an activity of RORCs, it was pleasing to see several of the RORCs director, including the current chairman and the incoming chairman and some others, have sat through these proceedings. And that's just to let everybody in the RAM world know that from a RORC's perspective, we do really value all of the work that RAM is doing. So thank you, everybody. That's it from me.
Thanks, Bruce. Thanks, everybody.
See you in Brisbane.
Thank you, everyone.
Thank you, everyone.
Take care.
Bye, everybody.
Bye, Tessa. Take care.
Bye. See you. Thanks, everyone.
Thank you.
Thank you.
Bye.
Bye, Wesley. Thank you.
Bye. Thank you.
Bye. Take care.
Bye.
Bye, everyone.
Bye. Bye, everyone. That's been fantastic.
I just wanted to say hello to former National Manager of RAM, Ian Sayers, that's been joining us for this meeting, as he has many others.
Oh, good.
Hello.
It's great to see him.
Hi, Ian.
Are you coming back to RAM? That's great.
I might be.
Oh, excellent. We're going to recruit you now.
I've sold my house and I'm moving.
Oh.
So